Welcome to Viewpoints, brought to you by Equichair, the leading provider of public safety software and training. My name is Sherry Bartram, and I will be your host today. A little bit about us before we get started. We are an international leader in public safety training and technology, with products geared toward providing tools to help responders stay safe and educated. For those of you who are new to our podcast, we offer monthly podcasts with a variety of guests geared toward public safety topics, as well as monthly webinars and a diverse offering of training courses through our apprentice platform. I encourage you to check that out as well. Today on our show, we are talking with Christanna Carrell about what she has witnessed with the legalization of certain drugs and the impact of that on newborns. Nurse Christanna, or Tana as she is known by, is a pediatric nurse in a state where the legalization of recreational marijuana has been in place for several years. She's going to share some information with us about the effects of marijuana as well as some other drugs on newborns. Tana has a Bachelor's of Science in nursing with experience spanning 3 different states and several ANCC board certifications. She has been a nurse for 14 years, working in many different areas of nursing, but for 10 of those 14 years, her focus has primarily been in pediatrics, specifically in neonatal intensive care units, or referred to as NICU, and women's health. She is certified in electronic fetal monitoring, neonatal touch and massage, and as a lactation consultant. Tana, you look so young to be so accomplished. It's so exciting to have you with us today.
I'm excited to be here.
That's great. For our guests, you might be wondering, especially if you've previously watched our podcast, what does this topic have to do with public safety? Well, when considering marijuana policies, there must be a consideration that our choices between regulation and prohibition have real consequences for family stability and newborn health. In addition, although substances have been legalized, the criminalization versus the medicalization of substances used during pregnancy does impact how people use these substances, as well as when they seek prenatal care or if they don't. And finally, for the 911 dispatchers and for the responders who show up on scene throughout the country, the 911 dispatchers who may be on the other side of the phone when the child is born or when that call comes in after the child goes home, of parents who have used the substances throughout the pregnancy. This is a very real topic that we just don't talk about. So, Tana, I'm hoping that you can shed some light on this topic that we really don't talk about.
Yeah, I will do my best to get some education out there and hopefully make you guys feel more comfortable with this topic in general.
All right. So let's just dive right in. Well, first I'd like to know just, I went over your credentials, which are, extensive. What made you want to go down that field into nursing?
I, even as a kid, wanted to be a nurse. So I kind of followed that path. And through high school, I did anatomy and physiology classes and really just enjoyed the medical field in general. And I really like helping people. So I feel like it was a calling, and I've stuck with it.
Okay. Oh, that's great. I love hearing the stories of people who had that calling and really just followed it all the way through.
Yeah.
Not all of us can say that. Some of us kind of stumbled into our profession and then we're like, wow, this is what I want to do.
Which is also
So
cool.
what's that?
Which is also cool.
Yeah, it's good when people find their calling.
Yes.
So let me ask you, has the legalization of marijuana in certain states affected what you're seeing in the neonatal unit?
Yes, the short answer is yes. It has affected, um, the number of patients we see. It affects how we treat patients. Even as they come in, we're assessing them more, checking into background more. Um, but it has in fact impacted our smallest population.
Your smallest population meaning the newborns?
Yes,
Okay.
our little tinies.
Your little tinies. Um, can you explain? I've heard this term, and I'm just not sure what it is. Maybe some of our viewers will understand it better. But can you explain what neonatal abstinence syndrome is?
Yeah, neonatal abstinence syndrome is a term that we give to babies who are withdrawing from certain drugs that they've been exposed to in utero. So while they're still in mom's belly, they've been exposed to these drugs, and then they withdraw after because they're no longer being exposed to said drugs.
Okay, so you've been a nurse for 14 years. Were you a nurse before the legalization of marijuana, before it became legal?
Yes, I was.
So have you observed changes with these shifting drug policies?
Yeah, there've been changes. There's an influx of moms that, feel that it's okay to use marijuana during pregnancy because it's legal. Um, and not really understanding the ramifications of the aftermath of a baby being exposed in utero. I think also, the population that would do it anyway feels like, oh, well, it's okay, so I can just do more. So there is more exposure happening.
Okay. So now I'm going to ask you a question to go in depth, and if you would. Public safety, we're terrible creatures, really. We really like to hear, and yet we don't. The good, the bad, the ugly. But keeping that in mind, what does a withdrawal look like in a newborn?
Um, so withdrawal is a spectrum. It can be mild and it can be very severe. Symptoms of withdrawal from most drugs are very similar. So methamphetamines, cocaine, marijuana, even things like Adderall, um, or Focalin, if a mom's taking those during pregnancy, um, anxiety medication, antidepressants, they can all have a similar effect on a baby, whether it's an upper or a downer. Those symptoms include tremors, pain. They have increased pain with withdrawal, just like an adult would. So they have a high pitched cry. They're restless, uncomfortable, diarrhea, vomiting. Um, a lot of babies need some kind of vestibular stimulation, so bouncing, moving, swinging, um, because they're spinning, their head is spinning. So giving them that little bit of movement kind of stabilizes them. Um, Other things, babies can have seizures if they have severe exposure. Um, I mean, there's so many things that we see in these babies. They need lots of comfort, mostly from the pain. And then I actually wrote down a whole list of things that I'm like, I know I won't remember all of these. Poor feeding, unable to eat because they're uncoordinated. A lot of that having to do with how their brain is reacting. Their nervous system is hyperactive in this withdrawal state. So everything is startling. Loud noises are intense for them. They can hear things more pronounced. Um, they have temperature instability. They get fevers. There's so many things that happen to these sweet little babies. Um, yawning, stuffy noses, sneezing a bunch. It's crazy how their body reacts to drugs. But I think the biggest things that we see are the tremors, the shakes, the rigid body, really stiff and uncomfortable, the diarrhea and the vomiting. And then just they don't want to eat because they don't feel good.
Right. That must be heartbreaking.
Yeah. Yeah, it makes you feel bad. They didn't choose that.
Right.
Yeah.
So there's really no differences in the variety of the subjects. The substance,
Right.
whatever, it's all the same to them.
Yeah.
You mentioned
Majority of it.
some ADHD drugs. So if the mom is on a prescribed drug, even, are they not told what that's going to do to their baby? Or, I mean, that's awful.
Yeah. Sometimes they are. And a lot of, if they have care, they have prenatal care, their OBGYN should be having that discussion with them. What certain doses will do, how the withdrawal will be for baby based on the dose that the mom is taking. And sometimes they'll play with that. The problem is not all moms want prenatal care or search out prenatal care. And so it's hard sometimes to get that education out there. Also, sometimes people take Adderall, just because they can. They have a friend or
Oh,
something.
okay. Okay.
Yeah,
So it's not necessarily their drug.
right,
It's just a drug. Okay.
right.
Well, so do you know right away, or what testing protocols do hospitals use to identify substance exposure in newborns? Do you test the infant or do you test mom?
Yeah, that's a good question. So, we get a detailed history, or as much as they'll allow us to get, right? Um, Based on a history, we often will do a drug screen on mom if we have concerns, or if we see signs of drug use, track marks, or behaviors that kind of indicate that they may be high. And then, of course, we always have to get consent for a drug screen on the mom. So we have to ask for permission, which we don't always get. Sometimes we do, not always. Um, so, if we have concerns and we don't get a drug screen on mom, or say mom came in and got treated for pain, she got fentanyl in the hospital, and then she flagged for opioids in her drug screen. Well, was that us or was that her? Right? So then we would do other things. We can test baby's umbilical cord. We get a 6-inch segment of umbilical cord and send that off to the lab. That can tell us how much is in their system and how long it's been in their system. So it stays in the umbilical cord tissue up to 3 months.
Yeah.
So if it's been in the tissue for a long time, we know, they've been using for longer than what they've been in the hospital for.
Okay. Um, so you've mentioned a couple times now that sometimes you don't get cooperation. How do you approach those conversations with the parents when a newborn tests positive for the substances? So you've tested the umbilical cord. Mom said, no, you can't test me. You test the umbilical cord. And now
Mm-hmm.
you have a positive test.
Yep.
Well, how do you start that conversation with a parent?
So at my facility, generally we have what we call a care conference. That includes the neonatologist or the pediatrician, uh, a nurse practitioner, the bedside nurse, the mom, social work, and then oftentimes developmental care will also be involved. That's usually like a speech therapist. Developmental care is speech, physical therapy, and occupational therapy. Um, so we as a care team come together and have a conversation with those parents saying, hey, we tested the umbilical cord. It came back positive for X, Y, and Z. Here's our next step. This is what we have to do as a facility to make sure your baby is safe. And then we try and get them to participate in that conversation, to kind of give us more information if they will. Um, and, trying to support them, because most often they're embarrassed. They're, they're feeling frustrated with themselves, and we can't fix that, but we also need to address that there's a problem. So usually that happens in a conference where we just have, one-on-one conversation with those parents.
I imagine so. In the world of 911, we're really trying to educate about unconscious bias and trying not to form opinions on people,
Yeah.
or when we do feel a certain way about someone. And actually, we've done podcasts with, people about who, our callers who call in who might have a drug problem, making sure our dispatch personnel out there recognize that if they feel some sort of a way, that those people are calling, they still need help, and to, check yourself, treat them with professionalism and caring, and you know
Yeah.
I'm trying to envision how you guys must feel in your profession. You're sitting there with the parents, and you have this newborn who didn't ask to be born in this state. um, wow. How does that take a lot of training, or like how do you handle that?
I think it takes practice. It also takes, you know, there are nurses that have no sympathy, no filter, right? They just say whatever they're gonna
Right.
think at the time. I think that's where it takes practice, is not just saying the things, but also trying to put yourself in their shoes. Or if this was my daughter, how would I want her to be spoken to? If this was my friend, how would I want her to be treated? And that's that way with everything, not just substance use and not just with newborns in the picture. It's with everyone. You don't know what people are going through or what path they've been on in life. So just really trying to remember that when you're in those situations, because oftentimes they didn't just, you know, decide, oh, hey, I'm pregnant. Maybe I'll try this drug and see how it goes.
Yeah.
They didn't want that for their baby either.
Right. That's a really good way to look at it. Like for us too in 911 and public safety, the people we deal with, they didn't necessarily mean to end up there. They just, one step led to another, and then,
Exactly.
there they are.
Yep.
Um, so you had mentioned when we were talking about the care, that they needed lots of care. What does the process of caring for these babies in the NICU typically involve?
So in the past, we've done lots of scoring, if you will. There's like, a chart that we go through that lists the symptoms of withdrawal, and you score them based on the severity of those symptoms. So tremors, are they jittery at rest? Or are they only jittery when they're being touched or stimulated? Do they have vomiting? Do they have diarrhea? How many times in 3 hours have they vomited or had diarrhea? Um, we looked at, like, how often did they sleep during that 3 hour period? Did they sleep for an hour? Did they sleep all 3 hours? And those things kind of tell us how severe their withdrawal is. And we still use those tools, but in the past we'd use that and then give a med, give morphine, give clonidine, give something that's going to help reduce the effects of that withdrawal. And then as their symptoms improve, we slowly decrease the amount of medication they get. We still do that a little bit. However, we have a new kind of protocol. It's called Eat, Sleep, Console. It's geared more toward holistic care for the baby. Instead of just pumping them full of pharmacologic intervention, we'd rather them have the snuggles, um, you know, be skin to skin with the parents or the grandparents or whoever's willing to be available for that baby. We even have cuddlers. At least at my facility, we have cuddlers that volunteer. They're mostly older ladies that have nothing else to do, and they come in and hold babies for hours at a time. And a lot of them come hold these babies that need extra care and extra love, because we know that that's one of the biggest things that helps these babies through the withdrawal. So Eat, Sleep, Console is just that. We feed them, we let them sleep, we console them when they're upset, and we really try to decrease the amount of drugs they need with those holistic interventions. Again, we still use the scoring tools because it gives us a good idea of where the baby started at and how we're progressing throughout treatment. And unfortunately, we still do have to give morphine for pain, for discomfort, for slowly weaning off of those drugs. And then clonidine is actually used to help decrease that excitability in the nervous system, so that hopefully we can prevent seizures and such.
Oh, that's just tragic.
Yeah.
So when do these symptoms show up? Like, are they born that way right away?
No, most babies, especially if the mom's been using, they still are receiving that drug throughout delivery. And we know, withdrawal doesn't happen right away. So most babies show signs of withdrawal around the 24 to 48 hour mark after delivery. So once they're not getting that constant flow of drug.
Okay.
Yeah. Now, I mean, it could be, things like opioids specifically. If we use those right away, like immediately before delivery, a baby could have a hard time breathing because that's a respiratory depressant. You're not going to want to take those big deep breaths after being born, after your birthday party. So, those babies often will need some kind of intervention, CPR, oxygen, something to help with their respiratory drive. But in general, NAS babies, it's 24 to 48 hours.
Okay. Well, so that brings up a whole new question from the 911 perspective.
Mm-hmm.
So, sometimes we deliver babies over the phone.
Yeah.
So, we get the call, my wife, my girlfriend is in labor, the baby's delivered and they have NAS. Or, maybe they went home and no fault of the hospital, right? They just sent him home because everything seemed okay 24 hours later.
Yeah.
And then the symptoms started showing up.
Yeah.
I don't know what to do. My baby's just screaming and shaking and seems to be in pain. Now, I would tell you as a dispatcher that I would, just dispatch it. But is there anything else, just so that we like to have closure? We like to know, well, what's wrong with that baby?
Yeah.
And if the baby's not breathing, if it's been delivered to a mom who just used, you said opioids, does marijuana ever cause that kind of immediate reaction at birth?
Not generally.
Okay.
Yeah. I have not ever seen a mom use marijuana and have the baby be respiratory depressed, at least to that severity.
Okay. So we would just, try and get them to start life-saving pre-arrival CPR, correct?
Yes. Yes. And most babies, especially the newborns, for the first few weeks, they thrive with respiration. So generally, giving them some rescue breaths will help them through. NRP always says to start with respiratory before CPR or before compressions for newborns, because we know their drive is based on respiratory status and not cardiac status like an adult.
Okay. That's interesting. which doesn't surprise me because most children and infant have healthy hearts.
Yes,
You
exactly.
know, if something's going to go wrong with their heart, it's, because they stopped breathing first.
Exactly. Yep.
Um, okay. Do you think the stigma around substance use during pregnancy changed when marijuana was legalized?
Um, I think yes and no. I think it's changed in that the way we react to things is different. Um, we're more cautious about how we treat patients, how we intervene with patients because we know a lot of the population is using. Um, I think that for, patients, for people in the public, they just don't know the ramifications. So why not try it? Why not use it? Why not do it? Um, and I think that there's like a breakdown in education where they just they just don't understand. And so I think yes, there is like yes, short.
Okay. Short answer. All right, you can leave it there. That's okay. Because the next question I'm going to ask is I'm just curious. Um, we're talking about the changes since marijuana has been legalized in so many states. Um, we have moms from teens till, in their 40s.
Mhm.
And with your career spanning, non-legalization to legalization, have you seen a shift in the age of the drug user, like the moms that come in? Are they older? Are they younger? Or is there no change? Do you know what I mean by that? Are they all younger, or has that age span grown,
Yeah. I think
broadened?
it has. I think a lot of our young population, they're in the phase of let's try, let's do this. This is the cool thing to do. So our teen pregnancies are very frequently um, positive for marijuana. But we have seen a steady increase in the 30s and 40-year-old moms who use recreational marijuana just sometimes during pregnancy. Um, and and for us, telling me sometimes means probably more than what you're willing to admit. you know, if you're saying you do it a couple times a week, you probably do it more than that. Like you just don't want to admit that you do that much. But yes, I think it's definitely shifted. So we have more older parents having positive drug screens.
Right. That's funny. That's such a funny thing that you said. If someone's saying they use, a couple times a week, it's probably a lot more than that. I remember many years ago talking to a young man who looked at my husband and I, looked us right in the face and said, "Yes, I do smoke weed about 3 times a week." Well, my husband's an officer, and we knew immediately that he actually meant to say day,
Yeah,
3 times a
exactly.
day.
Yeah,
Oh,
even
I got that week and day mixed up. My bad.
yeah, even when I did, adult medical surgical, you'd ask about alcohol use, and they're like, "Oh yeah, once or twice a week." Your liver enzymes tell me otherwise, buddy. Like,
Right, right.
yeah,
It's crazy.
yeah.
Okay, so no, I don't know if you've had a chance to study, or if these studies have been, if you've had this education, and I don't mean that in a negative way, but uh, and I actually don't know which state legalized marijuana, which states legalized marijuana first, but um, do you know what the short and long-term developmental concerns are for babies who are exposed to marijuana in utero?
Um, yeah, so short term, as far as, while baby's still in the uterus, we know for a fact that babies have low birth weight, intrauterine growth restriction because blood flow is not as good, especially when we have drug use, and then preterm delivery as well, are more common. And that's like, immediately after. That's like the immediate effect, right? Or the during effect. But those can have long-term ramifications too. If you have a preterm baby who isn't growing well, then you have brain development issues, you have ADHD issues, you have kids that have an increase in behavioral issues. Even, 9, 10, 11, 12-year-olds that were NAS babies exposed to marijuana have higher risk of ADHD, behavior issues, outbursts, and such like that. So that's one of the biggest long-term concerns is those developmental issues, the hyperexcitability of the brain, because we know that drugs have that effect on our babies, and it does carry through as they grow.
So is there a known age when these little innocents grow out of it?
No.
No, there's not, or there's not known?
There's not known.
Okay.
Yeah. Yeah. Or not enough research to say one way or the other. Right?
Okay.
We're still working on that. And research takes a really long time.
Well, it does. Unfortunately, we have to have kids go through it so we can follow them.
Yeah. Unfortunately.
So you've mentioned education when we're talking about the misconceptions from your clinical experience.
Mm-hmm.
What misconceptions do you think you see most about marijuana use? And maybe, we've touched on some other drugs. Primarily, I wanted to talk to you about marijuana use because it's legal, but you can talk about some other drug use as well. What are the misconceptions you see?
I think the biggest one that we see is that people just don't believe that it's a problem, right? If it's legal, I should be able to do it while I'm pregnant. Or it's not going to have that much of an effect on my baby if they've legalized it. And I think that education is huge, right? Because if we don't teach people, then they don't know.
Okay.
And same thing with alcohol or cigarettes. Nicotine is one of the worst withdrawals that we see in babies. They have more severe symptoms with nicotine, and especially if a parent is using marijuana and smoking cigarettes or any other drug and smoking cigarettes, their withdrawal symptoms are exponentially worse. But cigarettes are legal. Alcohol is legal, right? And I think that's such a misconception that we legalized it, so it's okay.
Right. And I thought as a society, we had done a pretty good job teaching people that smoking cigarettes while you're pregnant is bad.
Yeah.
I even remember some commercials, of the baby, showing a cartoon baby in the womb smoking a cigarette, and they just made it look so awful, and how bad that was for the baby and the baby's lungs. So I thought we did a good job doing that, but then I never understood the people who thought all of that, but it's okay to smoke weed.
Yeah. Because also people don't believe that marijuana has a negative effect on your lungs like tobacco or nicotine.
Okay.
Because it's same with e-cigarettes. We know that it's detrimental, but it can't be that bad, right? Because it doesn't have tobacco. It's just the nicotine. Well, no, it's still very harmful.
Okay. Um, all right. So, um, what do you think is needed most right now then? as far as to correct those misconceptions?
I mean, somehow we need to get education out, right? We need to teach people. It's hard because it feels like there are lots of, educational ads and things, substance use is bad during pregnancy. But I think for marijuana specifically, it's a very different thing. It's not illegal drugs. And we haven't learned enough about it for people to say, oh, it really is bad, like cigarettes or like alcohol. So it's like this weird in between where they just don't quite believe the education. Research will help, right? The more research we do, the more information we get, hopefully the better people will listen, or the more they'll realize that we weren't kidding when we said it's not good for you,
Right.
or your baby. Um, it's just hard to get that information out there, and to get them to listen to it.
Right. That sounds like that's probably one of the big things. Do you see, do a lot of moms, um, their child gets taken away?
Yeah, so when we have that care conference and we bring, all of the staff in and social work, generally we open a CPS case at that time. And that depends on situation too, right? Like if we know that a mom's using Suboxone or methadone for an addiction, that baby still will probably withdraw from methadone or Suboxone. It will be less severe withdrawal than it would be with um, substance use. But um, if we know that they're using medications like that, it's less likely for CPS to say, oh, okay, well, you can't have your baby because you're using drugs that are not good for them, because they're working towards that end goal, right? They're trying to do better and be better and get clean. But we always consult with CPS. We always get a caseworker involved, to make sure that that baby's going to be safe, have safe placement, and get what they need throughout this like initial period after withdrawal.
Okay.
Mm-hmm.
Um, how do you balance that respect for, the parents and the concern for the newborn's health when the substance use is involved? So, the parents, um, just their need to stay private and, um, like, are they allowed to come and see their child when the child is going through withdrawal? Or are there some parents, moms who their embarrassment is so great that they just don't want to?
Both. They're allowed to come, um, unless there's a specific reason why we say they are not allowed to come, or why CPS says they're not allowed to come. Just 2 weeks ago, maybe 3 weeks ago now, we had a situation where we had an NAS baby. The parents were sporadic at coming. The mom was positive for um, fentanyl, methamphetamines, heroin. Um, she had THC in her system, and like she had like 5 different substances in her system. And she said she wasn't ready to get clean. She wasn't in a place where she felt like she could get clean. Um, the dad and his family were there, but the dad was also not clean. And he was angry. He was very angry at us for calling CPS and threatened us with a gun. So he no longer gets to come to the hospital. Um, and then, that's like an extreme situation. That's happened a few times. Most often they aren't allowed to come when they threaten harm to staff or patients. And otherwise, we really encourage parents to come because their baby needs love. They need to be held. They need to be, that eat, sleep, console, right? the best thing for them is family to like love on them and hold them. But a lot of times they are just too embarrassed, too down on themselves, or not ready to stop using, and so they just stop coming. So we see both ends of that.
Hmm.
But the best thing for those babies is that connection, that love. So even if the parents can't come, we encourage their families to come. If grandma and grandpa can come, or aunt or uncle, or someone that's willing to, come and snuggle and love on that baby, that's what we want for them. Giving them the respect, it goes back to that knowing that they probably didn't do this intentionally. This wasn't a choice they wanted to make. And trying to kind of encourage them throughout without blame.
Yeah.
Obviously you did the drugs, you made the choice. We know that's not always the choice you wanted to make, but that's the choice you did make. And so, we're here to help you and support you. We need you here. Your baby needs you here, but now it's
Right.
on you.
Right.
Yeah.
Well, and so the last question I have for you is you mentioned research about prenatal marijuana exposure. You think more research is needed. Um, what kind of research? Like I was trying to think about that. What kind of research would that be, do you think?
Um, you know, it's a lot of testing baby on, like obviously low birth weight and IUGR, intrauterine growth restriction, and premature delivery. These are all things we can see happening. But research more in depth, like what else on a physiologic level is happening in the baby or in the mom that's causing these things to happen. And then on the outside of that, what things are happening in the baby's body after delivery that are affecting them long term. What things could we do to maybe help, alleviate some of those symptoms and change how they react later on? But research in utero and how it's affecting the baby as they grow, I think, is the biggest need. The hard part is, how do you get someone to say, "Hey, do research on me"?
Yeah, right. Yeah, you can use my baby.
Yeah, exactly.
Right,
Um,
right,
so that's, research in anything is hard medical wise, right? Because we don't have, especially in babies and kids, people don't want to subject their children to research. That's a scary term.
right.
Um, and so that's, probably one of the biggest obstacles. But I think that understanding how it affects a fetus better could help us better understand those long-term ramifications and then getting that education out there.
All right.
Mm-hmm.
Well, Tana, is there anything you want to add to our discussion?
I think so. This was good. This was a good conversation.
It was, and you have taught me so much today. For our audience, I just want to add that Tana, I have I have interviewed her brother. I have interviewed her little brother. I have interviewed her little sister. Tana is my daughter. I could not be more proud. um, this is really cool
Yeah.
that I was able to talk to her, and she taught me so much. I mean, obviously, I've known that she's been a nurse, but I really didn't know everything she did. And, being able to tie it into what I've done all her life, it's just been just a privilege. And so, thank you very much, Tana, for joining me in this podcast.
Yeah. Thank you for asking me and trusting me with information. And I really enjoyed it.
Great.
Yeah.
All right. And for our audience, I hope you enjoyed the information and I hope you could learn something from it.
Yeah.
Um, if there's any topic that you would really like to see us explore, feel free to contact me at Equiture, cbartram@equiture.com. And I'm glad you were with us today. Have a great day.